For the motor portion of the examination maneuvers are going to consist of manual muscle testing, and it's going to include reflexes, and it's going to include girth measurements of both the thigh and the calf. And so we'll talk about each of these manual muscle testing, reflexes, and girth measurements here in sequence. Now, the AMA guides describe manual muscle testing, and manual muscle testing is specifically described in Chapter 15, the Spine chapter. It's mentioned in Chapter 16, the Upper Extremity chapter. It's mentioned in Chapter 17, the Lower Extremity chapter. But nowhere in the guides is there any specific mention of the technique for manual muscle testing. And so I go through some technique discussions here in this program. And I've referenced several textbooks and references for the description of manual muscle testing that I'm about to give you here. And I provide those references for you in your handout materials. For testing cranial nerves, same general outline applies. However, that's beyond the scope of this particular program, and we do go into that testing the cranial nerves in another program, which is entitled The Importance of the Neurologic Examination. So I encourage you to also get and study that program as well. Now, let's talk about some of the motor pathways that provide for voluntary control of skeletal muscles. The first of which is the lateral cortical spinal pathway. And this plus the anterior cortical spinal pathway are going to give us the majority of our voluntary motor control that we're concerned with in testing the upper extremities. So with both of these pathways, the testing begins with your examinee having a conscious will to produce muscle tension. And the conscious will to produce muscle tension begins with a discussion from you, the examiner, explaining fully to your examinee what it is you're trying to do and what it is that you want them to do. And then secondarily, by engaging their competitive spirit and getting them to participate fully in their exam, this engages the conscious signaling of the muscles. And this conscious signaling happens through the upper motor neurons, which are projected downward into the spinal cord. In this case, we're dealing with the spinal cord at the level of C5 to T1. It's projected down into the spinal cord into either the anterior or lateral cortical spinal pathway. From its synapse in the spinal cord in the ventral horn, these first order neurons synapse with lower motor neurons, which then continue the willful impulses from consciousness out to the skeletal muscles in the trunk and to parts of the limbs. The anterior cortical spinal pathway would project to skeletal muscles in the proximal parts of the limbs, and the lateral cortical spinal pathway will project to skeletal muscles in the more distal parts of the limbs. So let's go over some procedures for manual muscle testing. And as I said, the exact procedure for doing manual muscle testing is not described in the AMA guides. The AMA guides do talk about doing manual muscle testing, but there's no procedure giving in the AMA guides for how to do it, etc. So I share with you here some general principles for manual muscle testing. Number one, you want to select movements for the examinee to resist that would just about match your own arm and ham strength. So select movements that are neither too strong for you to possibly overcome nor too weak for you to judge their resistance. Okay? So, for example, if you are testing resisted shoulder abduction in a small female and you're a large male examiner, you want to not apply your resistance to their wrist or hand area. You would shorten the lever up and give your examinee a little bit more mechanical leverage and mechanical advantage by placing your resistance at the elbow rather than at the extended arm at the wrist and hand, because that's just simply too long a lever and your examinee would be too weak in that position, and you would not be able to accurately judge their resistance. So select movements that are neither too strong for you to possibly overcome nor too weak for you to judge their resistance. So in contrast to that example, if you were to be testing a muscle builder guy, 250-pound muscle builder guy with deltoids the size of bowling balls, when you test resisted shoulder abduction on him, you do want to make sure that you extend his arm out fully and you apply your pressure to his wrist or top of his hand. In this case, you increase the length of the lever to give yourself mechanical advantage. Principle number two is to understand that muscles are strongest when acting from their shortest length and have little or no strength when acting from their longest position. Therefore, to test muscles of weak or modest strength, start with the muscle in a position of strength. To test very strong muscles, place the muscle in a position of disadvantage to bring them within your own range of strength, and I just gave a couple examples of how to do that. Principle number three, engage the examinee and get their competitive spirit into the game. Encourage them to put forth their best effort. And in this vein, you may want to perform several repetitions to get them engaged. And also several repetitions serves to get them familiarized with the test maneuver and get them accustomed to applying resistance through the particular muscle group that they're involved. And I'll usually have them do 2 to 3 to 4 efforts, and I judge the third and fourth effort as representative of their best effort. I don't use the first or second efforts, first or second attempts as evidence of their best efforts until I'm certain that they know what they're doing and that they're fully warmed up and ready to put forward a maximal contraction. Principle number 4, test in a repeatable superior to inferior direction. Number 5, always stabilize the proximal joint to prevent muscle substitution. Stabilize the proximal joint. So, for example, when testing resisted shoulder abduction, you would stabilize the scapula. For testing resisted elbow flexion, you would stabilize the humerus. For testing resisted wrist extension of the radial nerve, you would stabilize the forearm, etc. Always stabilize the proximal joint to prevent muscle substitution. And so in this program, we're going to talk about specific manual muscle tests for the upper extremities. In other programs, I describe specific manual muscle tests for the spine and for the lower extremity examinations as well. In this program, of course, we're focused on the upper extremities. Okay, let's go on now to a discussion of reflexes. Reflexes are actually a part of both the sensory and the motor examination. I include it here as part of the motor examination, but actually a large part of reflex arcs involves the sensory side of the loop. So really, reflex testing tests the entire circuit of sensory and motor functions. So in the lower extremity, we have several different reflexes. We have the adductor reflex, we have the knee reflex, we have the ankle reflex, we also have medial and lateral hamstring reflexes. And the adductor reflex and the hamstring reflexes might not be reflexes that you generally do as part of your examination, but there are good clinical reasons for including them in your reflex exam, and we'll summarize the clinical significance of the reflexes here in just a moment. For now, let's talk about the components of a reflex arc. So imagine this. And I know you've elicited reflexes 1,000 times, maybe 2,000 if you do it bilaterally. But think about this. You're in the exam room, and you have your reflex hammer. And how many times have you reached over and done a biceps reflex, or a patella reflex, or an Achilles reflex? You've done that thousands, tens of thousands, I don't know how many times, but probably many, 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 many. And probably, if you've done it 1,000 times, it was 999 times ago that you forgot what the components of a reflex arc are. And so you just merely went about the routine procedure of tapping reflexes, and in the presence of what appears to be a brisk reflex, you conclude that nerve function is intact. And that's actually true. But I want to refresh your memory here about the components of a reflex arc and bring those components back up to your consciousness so that you realize what it is you're actually testing, and even more importantly, what does it mean when we have normal reflexes. Well, let's explain that here in just a moment. So let's talk about the components of a reflex arc. First of all, the first component involves a stimulus. And in the case of deep tendon reflexes that we do in the examining room, the stimulus involves a rapid stretch of a muscle or tendon. Actually, it involves rapid stretch of a muscle, but we call these deep tendon reflexes, so we're going to say that we use the tendon in order to produce a rapid stretch of the muscle. And it's the rapid stretch of the muscle that serves as the stimulus to initiate the reflex arc. The second component of the reflex arc is a receptor. We have to have a specialized receptor, a specialized sensory ending that can detect the stimulus. And in the case of deep tendon reflexes, the receptors are specialized receptive endings that are located, embedded deep within the belly of the skeletal muscles. And we call these muscle spindles. Really what these muscle spindles are just specialized receptive endings of these unipolar sensory neurons that we talked about a little bit earlier. So it's the receptor that is going to detect the rapid stretch of a muscle or tendon that's imparted by your reflex hammer. The next component of the reflex arc is the sensory nerve. So once this rapid stretch of a muscle is picked up by this specialized receptive ending, which we call the muscle spindle, this muscle spindle causes an action potential to be generated in the peripheral process of this afferent neuron. This action potential, which we can simply call a nerve impulse or an impulse, this impulse travels up the peripheral process towards the nerve cell body. Now, where is the nerve cell body located? The nerve cell body is located in the dorsal root ganglion. Remember, in the lumbar spine, the dorsal root ganglia is located several inches away from the spinal cord, because the spinal cord ends at around the L1 to L2 spinal level. So these dorsal root ganglions are right medial or right interior to the vertebral neuroforamen, where the nerve root exits. So the impulses travel up the peripheral process towards the nerve cell body in the dorsal root ganglion, and then from the dorsal root ganglion, that impulse continues up the central process, and the axon of the central process terminates in the spinal cord. It enters the spinal cord through the dorsal root. Once in the dorsal root, it enters the spinal cord, which is now in the central nervous system. Central nervous system, as we described earlier, is basically the control center that then has to integrate and decide the significance of this incoming sensory impulse, and it's the control center, or the central nervous system, that decides the correct response. And there is a very specific response that the spinal cord ascribes or assigns to rapid stretch of a peripheral muscle. We'll talk about that shortly. So the signal arrives to the spinal cord, and the sensory neuron enters the spinal cord through the dorsal root and makes a synapse monosynaptically with the motor neuron. The motor neuron cell body is located in the ventral part of the gray matter of the spinal cord. It's located in the ventral horn. The synapse causes a nerve impulse, meaning an action potential, causes this neuron to depolarize, creating an action potential, which we'll just simply call a nerve impulse, and it sends this impulse down the motor ventral root, down the cauda equina, down to the exit foramen, where as the ventral root prepares to exit the neuroforamen, it then joins this incoming sensory root to form the exiting spinal nerve. As it forms the exiting spinal nerve, that neuron finds its way eventually back to the muscle, and in this case, if we're talking about the quadriceps the knee jerk reflex, this motor neuron then ends up back down into the quadriceps through traveling through the femoral nerve, and it creates a synapse at the quadriceps muscle at a junction that we call the neuromuscular junction. Once at the neuromuscular junction, this nerve impulse causes the release of chemicals to be released from the neuromuscular junction, which then initiates a series of events in the muscle known as excitation, contraction, coupling, which ends up causing the effector, which in this case is the quadriceps, might also be the gastrocnemius, might also be the adductor muscles, but in this case the effector is the quadriceps, and it's the quadriceps that then carries out the response. In this case, the quadriceps causes a contraction. The quadriceps contract, causing a rapid shortening of the muscle in response to the initial stimulus, which was a rapid stretch or rapid lengthening of the muscle. So, quick review of the components of a reflex arc is, number one, we need to have a stimulus. Number two, we need to have a sensory neuron or a sensory nerve. Let me back up here. Component number one, we need to have a stimulus. Component number two, we need to have specialized receptors to detect the stimulus. Component number three, we need to have a sensory nerve. Component number four, we need to have a control center, that's the spinal cord. Component number five, we need to have a motor nerve that carries the impulse back down to the effector. And then component number six, we need to have an effector. Now, in the peripheral nervous system, the effector is a limited population of tissues. For the somatic nervous system, the effectors are skeletal muscles. And with the knee-jerk reflex, we are talking about skeletal muscles. We're talking about the quadricep muscles. But also, other effectors could include glands, could include smooth muscles of arterial walls, could include erector pili muscles. In other words, we have both somatic and autonomic reflexes. For right now, the effectors involved with our motor testing of the lower extremities are skeletal muscles. And so for those of you that have the PowerPoint presentation, if you don't have it, refer to your handout materials. Show a diagram here, a simplified diagram of a standard reflex arc, which shows the reflex hammer coming down and tapping the quadriceps ligament or the patellar ligament. A quick tap on the patellar ligament causes a rapid stretch of the quadricep muscle. That rapid stretch is picked up by the specialized stretch receptor known as the muscle spindle. That causes a depolarization of a unipolar neuron, which has its nerve cell body in the dorsal root ganglion, and the nerve impulse continues up the peripheral process, becomes integrated in the dorsal root ganglion, and continues in the central process to synapse in the gray matter of the spinal cord. It synapses monosynaptically with a neuron in the ventral horn of the spinal cord, whose axon leaves the spinal cord by way of the ventral root and then continues down out the spinal nerve into, in this case, into the femoral nerve, into the L4 portion of the femoral nerve, back down to the quadricep muscle, where it makes a neuromuscular junction at the motor unit, and it's the quadriceps that then is the effector that carries out the response that we can pick up clinically, and that is the jerk of the lower leg forward. So some significant reflexes that are involved with the lower extremity, in addition to the knee jerk and the ankle jerk, include the adductor jerk, which is exclusively an L3 reflex. So in order to induce the adductor jerk, you simply place your finger over the adductor tendon down low by the knee and tap it with the hammer, and in the presence of a normal adductor jerk, you can conclude that at least the L3 afferents, efferents, and L3 level of the spinal cord is functioning properly. The knee jerk reflex is an L4 reflex mediated through the femoral nerve. The ankle jerk reflex is an S1 reflex mediated through the tibial nerve. And then the medial and lateral hamstring jerks are both S1 reflexes, but they are clinically different in that the medial hamstring reflex, and I'm talking about the reflex of the semimembranosus and semitendinosus muscles, is mediated through the tibial nerve, and the lateral hamstring reflex is mediated through the peroneal nerve through its innervation of the short head of the biceps femoris muscle. So depending upon the presence or absence of either the medial or lateral hamstrings, you can make a distinction as to which of the two nerves, be it the tibial nerve or the common peroneal nerves, may be affected by a peripheral nerve lesion. So some significant reflexes that are involved with the lower extremity, in addition to the knee jerk and the ankle jerk, include the adductor jerk, which is exclusively an L3 reflex. So in order to induce the adductor jerk, you simply place your finger over the adductor tendon down low by the knee and tap it with the hammer, and in the presence of a normal adductor jerk, you can conclude that at least the L3 afferents, efferents, and L3 level of the spinal cord is functioning properly. The knee jerk reflex is an L4 reflex mediated through the femoral nerve. The ankle jerk reflex is an S1 reflex mediated through the tibial nerve. And then the medial and lateral hamstring jerks are both S1 reflexes, but they are clinically different in that the medial hamstring reflex, and I'm talking about the reflex of the semimembranosus and semitendinosus muscles, is mediated through the tibial nerve, and the lateral hamstring reflex is mediated through the peroneal nerve through its innervation of the short head of the biceps femoris muscle. So depending upon the presence or absence of either the medial or lateral hamstrings, you can make a distinction as to which of the two nerves, be it the tibial nerve or the common peroneal nerves, may be affected by a peripheral nerve lesion. Now, when it comes to your report, you want to provide your reporting of your findings of your reflex testing in such a way that the reader of your report understands that you understand what normal reflexes actually indicate. And so let's go back to those 6 components of a reflex arc. If you think back to the 6 components of a reflex arc, many structures have to be working correctly in order to produce a brisk, or what we would consider to be a normal reflex. So with regards to only the knee jerk and ankle jerk reflexes, the following would be an example of how you could report your findings in the body of your QME report. And I provide this template for you in your handout materials for this course, should you choose to implement this into your exam report template. So you would indicate in your report a chart that that names the reflex, and then another two columns where you can indicate your findings for the left leg and your findings for the right leg. And in the presence of normal reflexes, which is 95% of the time, I find in my experience normal reflexes 95% of the time, unless there's been some old radiculopathy or what have you, your report would go as follows. And this is a quote. The lower extremity reflexes were normal and symmetric bilaterally. And let me just pause here. Most times when you read other doctors' reports, you don't even get that much description. Typically, most doctors will simply state that the reflexes were normal. And I don't know what that means. That is not enough detail. It doesn't even tell which reflexes were tested. Further, it doesn't convey to the reader of the report what normal reflexes mean. Remember, these reports are read by lay people. Lay people have no idea first of all, what a normal reflex is, and second of all, what does a normal reflex indicate. So it's my opinion that your report should provide the reader with the conclusion, the natural conclusion of what it means. So I'm going to continue with the report. Excuse me, there was a phone call coming in. So let's continue. And this is a quote from the report. This indicates preserved function of colon. And here you make a bulleted list. It indicates preserved function of the left and right quadricep muscle spindles. Those are the stretch receptors. And recall that that is the second component of the reflex arc. So you're indicating here to your reader some normal structures. It indicates preserved function of the left and right gastrocnemius muscle spindles. Left and right femoral nerve sensory function. Parenthesis L2, L3, and L4, and L4 is in bold. Nerve roots. Left and right tibial nerve sensory function. Parenthesis L4, L5, S1 in bold, S2 and S3 nerve roots. Left and right femoral nerve motor function. Left and right tibial nerve motor function. Left and right quadriceps muscle function. And left and right gastrocnemius muscle function. So here to your reader, you indicate that each of the components of the reflex arc are functioning normally for each of the reflex arcs that you test. Now, in my opinion, that is very compelling and indicates to the reader of your report your attention to detail and your meticulousness in interpreting the results of your examination. And if you then go ahead and do the adductor jerk and the hamstring reflexes, you would simply repeat the same language in the body of your report.